good evening. My name is Kathy Posnick, and I'm the chapter coordinator for the CSF Foundation, Chiari and Syringomyelia Foundation. And thank you for all coming out tonight. I want to throw a special thank you out to Susan for helping us with registration, and we appreciate that. Thank you. Tonight we are so happy to be here in Ann Arbor, Michigan, with Dr. Cormac Maher, presenting the lecture, Chiari Research Update, What We Don't Know, But Really Should Know About Chiari Malformation. Before we start this lecture, I want to tell you a little bit about CSF and what we've been doing. First of all, CSF is very proud to be the only charity for Chiari, Syringomyelia, and related disorders like hydrocephalus and Ehlers-Danlos syndrome that has met the 20 rigorous standards of the Better Business Bureau seal. We have also earned the Gold Star from GuideStar and are working on the Platinum level, which just rolled out very recently. In addition, we have obtained the Health on the Net code, which is called the HAN code. That means that the information you find on our website is reliable, current, and accurate medical information from physicians. In regards to education, to date, CSF has hosted over 200 of lectures like this evening. We have had 25 national and international locations. Our Vimeo account statistics are quite impressive. There's been 500,000 people have accessed these videos from 144 countries worldwide. Last year, CSF hosted 2 major medical meetings, the think tank in Washington, D.C. and the colloquium in New Orleans. The CSF Colloquium Research Meeting has produced 2 books, Vascular Impression and Hypermobility at the Cranio-Cervical Junction, and Comorbidities that Complicate the Treatment and Outcomes of Chiari Malformation, and those are on lulu.com. The CSF calendar is quite impressive with what we have lined up so far for 2016, and we are looking forward to hosting this year's think tank at the end of this month in Chicago. And if you go to the csfinfo.org website, you'll see their calendar is quite full. We are continuing to work to establish chapters nationally, and then we hope to move on to international chapters. We currently have 38 chapters of support in 28 states. In regards to awareness, last year CSF organized over 52 United Night Walks, which raised over $120,000 and had over 2,300 registered walkers. So far in 2016, we have 62 walks on the calendar, and we are excited that we're adding a 5K run to the Las Vegas walk. In addition, I'm very happy to tell you that we have 4 walks scheduled in Michigan. There will be a walk near here in Jackson, Michigan on August 13th. Amy Haas is the walk chairperson, and please ask her questions. She's up there, and there's flyers in the back, and we'd love to have you join us. In addition, there's a walk in Greenville, Michigan on June 25th, Kalamazoo, Michigan on July 31st, and Mount Pleasant, Michigan on June 18th. Yay, Michigan! We're happy we have 4 walks. In an effort to raise awareness and funds, CSF hosts 4 signature events, and we're adding more each year. We recently had the Charity Ball Casino Night in Staten Island on March 12th. We have the Bobby Jones Classic for CSF that will be down at the East Lake Golf Club in Atlanta, Georgia on May 16th. Some of you may know that Bobby Jones, the golfer, had Syringomyelia, and we work with the Bobby Jones family. We hold the dinner dance in Twinsburg, Ohio, where I'm from, and that's on October 22nd, and it's not a far drive, so you can come join me there in October, the end of October. And we have the CSF Night of Light Children's Gala in Washington, D.C. And finally, we're adding a dinner dance auction called Shine a Light on CSF in Chicago on October 8th. So you can also come out there to see us and have some fun with us. In 2015, the Hydrodynamic Symposium was held in France with 25 presentations from engineers and scientists from around the world. The lectures are available on our website. We have 3 major programs and dedicated research chapters opening in 2016 at Brown University with Dr. Petra Klinga. She's the director on the CSFC board. And Brown University has received a $1 million grant that includes an optogenetics research project to control the production of CSF in the brain using light. and the opening of a CSF research center under her direction. CSF is working closely with her and will launch a new initiative on June 25th, and along with the United Night Walk being held that Friday night before. At Johns Hopkins with Dr. Mark Luciano, who is the vice chair of the C-Board, we are working on a program to inaugurate the new CSF program at Johns Hopkins headed by Dr. Mark Luciano. Third dedicated research center is at St. Louis Children's Hospital. Dr. David Limbrick is another CSF board member, and a $2.8 million grant has been awarded to Dr. Limbrick to lead a comparative surgical study on whether to open the dura or to leave it intact when performing posterior fossa decompression. Another thing I want to tell you about real quickly is the International Registry Project. Even though it's 2015 and medicine has advanced, the truth is many physicians agree that the definition of Chiari has to be re-examined. Is it a certain level of herniation? Is it 5 millimeters, 3 millimeters, 0 millimeters? Well, I guess 0 isn't millimeters. Is it a particular set of symptoms? Even the experts agree that this is a problem because it makes it difficult to determine which patients need surgery and which patients do not. Recognizing that this is a problem for both patients and doctors, CSF staff and medical steering committee of the CSF Scientific Education Advisory Board have been meeting after hours for the last couple years to write what the NIH calls Common Data Elements, or CDEs. Common Data Instruments, CDIs, and Clinical Research Forms, CRFs, for Chiari and Syringomyelia. And Dr. Maher may say a little bit about that later tonight. This will help standardize the measurements and instruments that researchers and clinicians will use during their studies. We are finalizing the detailed documents and have begun releasing sections to the NIH, NINDS for formatting and public comments. The unbelievable part of this entire project is that we have collaboration from over 35 medical institutions nationally and representation from China, Japan, England, Spain, France, Switzerland, Italy, Germany, Australia, and Canada. Next, CSF will begin designing an international registry that includes these elements. Because Chiari studies tend to be small, the standardization of measurements, terminology, and fields in an international database will enable researchers and clinicians to answer basic questions that patients, physicians, and scientists have been asking for years. Very excited about this. This is a slow process. Research and development are very expensive. So CSF will continue to raise much needed funds for our research endowment and the registry project. If you know of individuals, foundations, or corporations that would support this project, please contact the CSF office. We need your help to ensure this project becomes a tool that provides answers for patients and researchers and clinicians around the world. We're looking forward to a successful 2016, and with your help, we can make a difference. Please consider getting involved. Again, our website is csfinfo.org. And real quick before I move on in the program, I wanted to share with you our 2016 United Night t-shirt. And our theme is I Am Hope. And you can earn this t-shirt at the walks by raising $50, but you don't have to raise any money. You can register for the walk and come and meet people. And again, see Amy afterwards. But just wanted to share the shirt with you for this year. So now I want to introduce our speaker. Dr. Maher is a graduate of Georgetown University, where he obtained a doctorate of medicine. He completed his internship and residency at the Mayo Clinic and moved to Boston for dedicated training in pediatric neurosurgery at Boston Children's Hospital. Soon thereafter, Dr. Maher completed fellowship training in cerebrovascular neurosurgery. Dr. Maher is an active clinician and investigator and has published over 130 scientific articles, as well as several book chapters on many topics. He is published in many journals, including the Journals of Neurosurgery, Stroke, and Neurology. He is a diplomat of both the American Board of Neurological Surgery, as well as the American Board of Pediatric Neurosurgery. He is a member of the American Society of Pediatric Neurosurgery and is a fellow of multiple professional organizations. He is on the editorial board of the Journal of Neurosurgery and is a director of the Accreditation Council for Pediatrics Neurosurgery Fellowships. Very special to us, he is a member of the executive committee of the CSF C-Board. and has been instrumental in helping with ongoing CSF projects, in particular the CDE and registry project I previously mentioned. Dr. Maher has actually helped us secure a grant that will allow us to begin work on the registry this year. So thank you for that, Dr. Maher. This time, I'd like to bring Dr. Maher up, and he will present his lecture.
Thank you very much, Kathy, for the introduction. I wasn't going to talk about the CDE project in particular today, but I'm happy to have any questions from the audience about that project, since it is a major endeavor from this group right now. Kathy's introduction, though, was, I think, was really helpful, talking about what we don't know about Chiari and some of the frustrations that I'm sure many people in the room have working through this Chiari process, dealing with doctors that sometimes are on the same page with you and sometimes are not, and sometimes have difficulty understanding what you're going through, hearing different things from different people, and I think trying to understand why that could be. How can we be in the 21st century and not know the answers to some of these very, very basic things that you're going through and that are important to your life and well-being. So I decided to title this talk "What We Don't Know About Chiari," but we really should know, because sadly I think what we collectively as a medical system don't know about Chiari is probably more impressive than what we do know at this point in time. I have no conflicts of interest for this talk. First, I want to recognize the collaborators that I have here at U of M. It definitely takes a village to properly take care of patients that are going through Chiari in their lives, and I'm very lucky here to work with a really great team of people, two of whom are sitting in the back row, and I think will be happy to join me in entertaining some questions from the audience later on tonight. Oren Sager is professor of neurosurgery here, and sees patients with Chiari, particularly adult patients with Chiari, and has a long expertise in dealing with that issue. And Corinne Marasco, who I'm sure many of you know, the chairman of neurosurgery here, and has had very many major contributions to our understanding of Chiari malformation over the years, including some really seminal work dealing with CSF flow and how that leads to problems with syrinx formation when it's associated with Chiari. And then you can see some of the other names listed here, some in the Department of Neurosurgery and some in affiliated departments. All of the names here have been involved in some major way with some of the research that I'm going to show you tonight and in the slides that are forthcoming. Again, all major contributors, and couldn't have done it without them. Does anybody recognize this? Anyone know what this is? So this is the Cat's Eye Nebula, okay? And I once saw a scientific lecture from an astronomer on the Cat's Eye Nebula, and I was amazed at the level of knowledge that we have about this structure. It's 3,000 light years from the planet Earth, and it seems like we know every single thing there is to know about it. We know what its temperature is in the halo, we know what its temperature is in its core, we know what its density is, we know exactly what it's composed of on a molecular, on an elemental level. We know exactly how big the central star is, we know what its age is. And this is a nebula that's over 3,000 light years away from the planet Earth. What don't we know about this? I'm sure an astronomer would tell you lots, but nevertheless it is impressive what we do know. But what do we know about this? This is a child with a Chiari malformation. Okay. Most of us would agree that by traditional MRI criteria, this child has a Chiari malformation. Well, how common is it? Well, I'll show you lots and lots and lots of research is being done trying to answer that very basic question, what I think is the most basic question. Is this rare? Is this common? Kind of depends what you mean. How do we make the diagnosis? As Kathy was alluding to, that's very controversial now. If you talk to 100 different well-meaning experts, you're going to come away with 100 different answers, and it's very confusing. It's confusing for experts, and it's certainly confusing for patients that are trying to work through this. Is Chiari associated with other conditions? Well, the answer is certainly yes, but which ones and how much? When is surgery helpful? Another very central question that we could talk about all day. What kind of surgery is helpful? Kathy was talking about the trial that's just getting started now with comparing randomizing patients for opening the door or not opening the door. Everybody has an opinion about which is the better thing to do, and now maybe we're finally going to have some actual scientific information. What's different between kids and adults? Can we treat kids like little adults? Is everybody with Chiari the same thing, or are there differences? We'll talk about that a little bit. Boys versus girls, same thing. So most basic question about Chiari. I think it's almost the number one thing that people want to know when they first get this diagnosis. They come back from their primary care doctor's office with a piece of paper in their hand that says the word Chiari malformation, and people want to know, am I 1 in a billion, 1 in a million, 1 in 100? How scared should I be? How rare is this? How common is it? Well, that's something we should be able to answer, but it's been relatively controversial. I think we're starting to settle on some common ideas. We, as a medical community, are starting to settle on some common ideas where there can be some agreement. But that's only a relatively recent phenomenon. This is the website for the National Institute of Health. If you Google search Chiari malformation, NIH, this is where you're directed. So the best medical authority in the country, this is where it takes you. And you'll notice that in the top row, it says the Office of Rare Disease Research. So for the NIH, they're running their Chiari operation, their Chiari funding through the Office for Rare Disease Research. But you may also notice here, there's a little asterisk, right? I didn't put the asterisk there. What does the asterisk mean? Well, I blew it up for you here, and it says, not a rare disease. So it's sponsored by the Office of Rare Disease Research, but then they have to say, well, oh, by the way, despite that, it's not a rare disease. So the NIH can't really decide about that, it seems like, or at least they're somewhat contradicting themselves. Well, why? Why can't they decide? Why can't anybody decide? Well, I think the reason is it goes beyond scientific truths and gets into philosophy a little bit. How do we define disease? The person on the right, let's say, has terrible headaches, pertussive, cough-induced. As you may be able to appreciate, there's a great big spinal cyst, spinal syrinx. I don't think that's very controversial. Everybody would say this person has a disease. Person on the left, let's say, has classic Chiari symptoms, tussive headaches, cough-induced headaches, other classic Chiari symptoms, trouble swallowing, that sort of thing. Okay, disease, Chiari malformation. What if they have no symptoms at all? What if they fell on the playground and somebody ordered an MRI, and this person has this scan, and now they've got a piece of paper from a radiologist that says they have Chiari malformation. Does this person have disease? Well, they're going to be sent to a neurosurgeon maybe, and that neurosurgeon is going to look up the code for Chiari malformation and attach that code to that person's medical record, and it's going to stick with that person. Does that person have disease or not? Well, I don't pretend to have the right answer, but in the United States now, the diagnosis is being attached to them. Okay. So when you ask how common is Chiari, this is one of the central problems we're running into. What are you talking about when you're talking about Chiari? Are you talking about the person on the right, the person on the left, with symptoms, without symptoms? This really matters a lot because symptomatic Chiari is, no matter what you decide is a definition for rare, is definitely more rare than asymptomatic Chiari. There have been a few studies of this. Here's the first one. It's from California. They looked at the Kaiser insurance group. So this is a very well-defined population of people because they all have the same insurance, Kaiser Permanente in California. They looked at about 750,000 children in California, and then they asked a very simple question. Who's having MRIs? Of those people who have MRIs, who's getting diagnosed with a Chiari malformation? And they found that over a 2-year period of time, the prevalence was almost 1 in 10,000. Okay. That is to say, almost 1 in 10,000 children were diagnosed with Chiari malformation in that group every 2 years. So that's not a really, really, really rare thing, but it's not that common either, right? We did a relatively similar study, but with a much larger insurance population recently. We looked at 58 million people that had a private insurance in America, and basically asked the same question: who's getting diagnosed with Chiari? And out of that 58 million, we found 33,000 people that were actually diagnosed with Chiari according to the code. That doesn't mean that there weren't more people that weren't diagnosed with Chiari that never got coded properly by their physician and so on. But what we're saying is that, okay, it's not rare, it's not unheard of, but it's not as common as some of the other numbers, which I'm going to show you for how often we're finding it on the MRI. Here's the whole data set. There's a million numbers on the screen. Don't try to read all the numbers, but what I want to show you, again, we're looking at big numbers. I was hoping the screen would be bigger. But inside the red there, you can see every year we're looking at 28 million people, 30 million people, 40 million people, lots of people is the bottom line. That's the bottom line with that part of the slide. And then who's getting diagnosed with Chiari malformation every year out of that group, and you can see that's in the red way over here. So it's several thousand every year in this private insurance company. And that gives us an annual incidence of Chiari diagnosis remarkably similar to the numbers I showed you from the Kaiser Permanente group. So, okay, I think that's good. We're settling around the number, a 1 in 10,000 number or so for the diagnosis of Chiari on an annual or semi-annual basis. Okay. The other interesting thing we found, as I'll show you though, that's the 2001 number. 2014, which is an up-to-date number, the first study I showed you was from way back in the 2000s range. But now in 2014, you can see that the diagnosis is being made much more commonly than it used to be. Probably not a surprise to anybody in the room. Who's getting surgery? Are we defining Chiari according to who's getting surgery and who's not? Well, that's a whole different category, and it's a much smaller group of people. And so here you can see that it's about a 1 in 100 thing or so, people getting diagnosed versus people getting surgery, at least on a year-to-year basis. I told you that the diagnosis was being made more commonly, and here it is. I think everybody can understand what this graph is showing. Starting on the left back in 2001, you can see that it's at a relatively low rate, and it's gone up and up and up and up since then. So Chiari is being diagnosed more frequently. I think a number of you in the room and a number of people in this organization have expressed frustrations over the years that Chiari is an under-recognized phenomenon and that it's difficult to find physicians who can make this diagnosis properly. And I think that that's true, and I think that you do meet a lot of people who have had unrecognized Chiari for a long time. The numbers are showing that to the extent that that's true, that's becoming less of a problem over time because the diagnosis is absolutely being made more frequently now than 10 or 15 years ago, a lot more frequently. In general, kids and adults, this is kids in blue and adults in red, and the main point of this slide is that kids and adults are going up, but at a break point in about 2009, the rate of diagnosing kids seemed to flatten out a little bit. The rate in adults, there's still no end in sight. It's still going up pretty steeply. More and more and more people are being diagnosed with Chiari malformation every year. With surgery, really the opposite is true. The trend line for kids, again in the blue line getting surgery, more and more and more kids are having Chiari surgery every year in this country. There's no question about that. The adults in red, it's been relatively flat, which I think is interesting if you consider that the diagnosis is being made much more frequently. In America today, people are more likely to be diagnosed, not necessarily more likely to be operated on if they're an adult, definitely more likely to be operated on if they're a child. That's what all of these graphs are essentially showing. Boys and girls. People have always assumed that women or girls are more likely to have the Chiari diagnosis and to be operated on than boys, and that's essentially true, and that's been true for a long time. Boys are in red, girls are in blue, and you can see that girls, ever since we've been tracking the data, in 2001, girls have definitely been having more Chiari surgery than boys. But that's not true at every age. That's just true in general. And age matters a lot. In this graph, we've broken down boys and girls versus how old they are. And you can see that in the really young kids, way over here, this is 0 to 5, 5 to 10 years of age. It's actually more common to see boys getting surgery in the really young ages. And this is absolutely, this is a huge numbers of patients. This is what's going on in America right now. Boys more likely to have surgery than girls at the really young ages. And you can see that the two lines cross. And then starting in the teen years and for the rest of their lives, girls and then women are much more likely to have Chiari surgery than boys. If you look at it a different way, again, boys are in red, girls are in blue, and this is just when people are having surgery and at what age. And you can see again in the early ages, in early childhood, boys outnumber girls, then it kind of evens up, and then every other age we look at, girls absolutely outnumber boys. So in adults, it's a mostly female population, there's no question. In kids, it's a mixed picture because you get teenage girls and very young boys, in general, exceptions to every rule. Where you live matters too. This is a national insurance database, again, millions of patients, and you can see that there's very substantial differences in terms of what your odds are of having Chiari surgery depending on where you live in the United States. If you live in the Mid-Atlantic region, your odds of having surgery is slightly less than half of your odds of having Chiari surgery if you lived in the East South Central region. So huge geographic variations in the rates of Chiari surgery according to where you live in America. So we talked about the definition problem. You can ask me how common is Chiari, and I can spend the next 2 days saying, well, I don't know, it kind of depends what you mean by Chiari. Is it this type of Chiari or that type of Chiari, or young people or older people? And it all comes down to this 5 millimeter rule when we're talking about MRIs. I'm sure most of you, or maybe even all of you in the room, are familiar with this 5 millimeter rule, the so-called 5 millimeter rule. It's the most important and basic thing that people learn about Chiari malformation when they're finding out about their MRI report, or when you're learning about Chiari malformation in medical school. And there's a lot of problems with the 5 millimeter rule, okay? But it's important at least to know what it is before we can start tearing it asunder. Lots of problems with the 5 millimeter rule, and that basically says that you have a Chiari if your tonsils are 5 millimeters below the skull. Okay, so we draw a line at the bottom of the skull, and we say your tonsils are allowed to be a little bit lower, but if they're more than 5 millimeters lower, we're going to call you a Chiari. And if it's less than that, we're going to say you don't have a Chiari. That's what the 5 millimeter rule says. Okay, and as I'm going to point out, there are major problems with that rule. Number one, Chiari zero, right? Many of you have heard the term Chiari zero. Jerry Oakes, several years ago, many years ago, noticed that there were some individuals that had a really tight area at the bottom of their skull, and they had a big syrinx, a cyst in their spine, just like Chiari patients had. But then they would measure the amount of tonsils in the spine, and they didn't have a Chiari malformation by that 5 millimeter rule. So we came up with this idea for Chiari zero. Okay, that's what that was supposed to mean. So that violates the 5 millimeter rule. What about asymptomatic Chiari 1? Well, I've shown you that the diagnosis is being made much more commonly than the surgery, and as I'll show you soon, it's even more common to see it in an MRI. So that violates the 5 millimeter rule, the idea that everybody with 5 millimeters is now going to be labeled in this way. That's a violation in my opinion. So what's it useful for? Well, I think it's a starting point. It's really easy to measure. Everybody can measure the amount that their tonsils are down. So doctors use it as a sort of a common language. This is how many millimeters this person has. Patients use it, frankly. I've seen, if I get on the message boards in Chiari communities, that's one of the first things that people talk about. And usually there's a qualification. You know, I've got this much measurement, but, and there's always a but, and there are important buts. But this is a starting point. People talk about their measurement. So it's easy to do, it's convenient, and again, there are important historical reasons for it because we've been using this language now for decades. So what is the evidence for using this language? Why do we talk about the 5 millimeter rule? Well, it goes back to this paper, a 1986 paper that was written by a group of radiologists from San Francisco. And 1986 is important because it's in the MRI era, but it's relatively early in the MRI era. So in the 1950s and 1960s, people could be comfortable with the idea that Chiari is really rare and you're never going to see it, and very few people even know what it is. But by the time the mid-'80s rolled around, we were getting MRIs on more and more people. And so we were starting to see Chiari malformation, but there was no strict definition for what that meant. It was essentially in the eye of the beholder. So this group were a group of very well-meaning and well-respected radiologists tried to put some order into this problem and said, okay, what is a Chiari malformation on an MRI? And they recruited 25 patients that had absolute symptoms of Chiari malformation. There's no doubt about that. And then they had 200 patients that were pre-selected for being normal patients, that is to say, patients that didn't have any neurological symptoms, and certainly no symptoms of Chiari malformation. And then they put those two groups together, and they just started to apply different rules. And they said, well, what if we say you can't have any brain sticking down beneath your skull base at all? You can't go below your foramen magnum at all, so a 0 cut point. Well, they said if we did that, we would capture all the patients that had Chiari syndrome, but it wouldn't be very specific. There'd be quite a few patients that felt great in that group as well. Okay, so what if we go 1 millimeter below? It's sort of the same thing. 2 millimeters, a little better. 3 millimeters, a little better. When they got to 5, they said that they were capturing most of the Chiari patients, but not all, interestingly. But it was 100% specific, meaning that if you had tonsils 5 millimeters below the foramen magnum, if that was your cut point, this was essentially diagnostic for their Chiari syndrome, for a symptomatic Chiari. And this was a very influential paper. After this, it essentially became a standard. It's been cited over and over and over again. People use this measurement now in a relatively unthinking way, many times, to diagnose the Chiari malformation. But I think it's important to remember when you're using the 5 millimeter rule, whether you're a doctor or a patient, that you understand where the information came from. And it came from a well-meaning attempt of physicians several decades ago now with a very small group of patients. And they were essentially working from very little information. And I think what they came up with was useful, but it wasn't the absolute truth. It wasn't truth that can't be questioned today now that we have better information. There were some chinks in the armor for this idea that Chiari was 100% symptomatic and diagnosable at 5 millimeters a few years after the paper that I just showed you. And this was really a breakthrough paper at the time. This was from Johns Hopkins, Meadows, and others. And they essentially looked at everybody that had an MRI at Johns Hopkins for any reason, at any age. And they said, if we look at all these studies, who has a Chiari and who doesn't? And you can see that they found 175 patients that had a Chiari out of the 22,000. And the really interesting thing about this paper, which was of interest, I think, to readers at the time, would not seem very remarkable anymore, but they found a lot of asymptomatic patients with Chiari here. So patients that met the MRI criteria for Chiari. They have a piece of paper now from a radiologist that says they have a Chiari malformation, but this was news to them because they felt great, or they fell on the playground, or what have you. So this was new. So the idea that 5 millimeters was specific for symptomatic Chiari is definitely not true. So again, back to this original question that I posed: how do you define disease? Is it going to be what we would call the clinical criteria? How are you feeling? What are your symptoms? How we're going to make a determination based on that? Or is it going to be on the basis of your MRI report? And I would suggest to you that that's a relatively confusing situation in America right now. And it's an important thing to figure out in America right now because we're ordering more MRIs than anybody else in the world. And we're ordering more and more and more every year. The graph on the left essentially shows you all the different lines or different regions of the country. Which region, which line doesn't really matter, but the important thing is no matter what region you live in, you're much more likely to have an MRI now. This is rate of MRI this is now, and this is in the 1990s. No matter what line you're on, no matter what region you're on, you're much more likely to have an MRI these days than you were 10 or 20 years ago. And it's a uniquely American phenomenon. This, on the right, you see information that I took from the Organization for Economic Cooperation and Development, the OECD, which is a UN-affiliated organization. They just look at health data from all around the world, and they ask lots of simple questions. What's the infant mortality? What's the rate of heart attacks? And in this case, what's the rate of getting an MRI scan? And you can see that in the United States, the rate of getting an MRI scan is 91 per 1,000 per year. In the OECD 11, which is 11 other first world countries, the rate is half that. Our neighbors to the south, Canada, 31. We're 91, they're 31. So if you cross the border, you have a 1 in 3 chance of getting an MRI versus if you live in America. So it's wonderful that we in America have access to all of these resources, all of these healthcare resources, easy availability of MRI scans and so on. But it does introduce uniquely American questions. What do we do with all this information? Because our ability to gather information, especially with respect to Chiari, has outpaced our ability to understand what to do with it once we have it. I already showed you this, new Chiari diagnosis, up and up and up and up. Kind of looks like the Smith-Bindman curve there on the left, MRI rates. Okay, so the same number of people I think are suffering from Chiari now as 10 or 20 years ago. I can't prove that, but it seems like a reasonable presumption. But the rates of MRIs are going up and the diagnosis is going up and up and up and up as well, even faster than the rate of MRIs is going up. So does tonsil position matter? I've just told you why I think the 5 millimeter rule is overrated, and it has problems both on the failure to diagnose end as well as the overdiagnosis end. But does that mean tonsil position doesn't matter at all? No, is the simple answer, and I'll show you why. Are people with lower tonsils more likely to have problems? So the first thing to understand about tonsil position is it's like anything else in the human body that you can measure. Some people are at one extreme, other people are at another extreme, and most people are kind of bunched up in the middle. So we call it a bell curve distribution, shaped like a bell, right? And I could show you a curve just like this if I was talking about height or weight or shoe size or head size or anything else. And when I measure where people's tonsils are in the human population, you get a bell curve as well. And this is the middle-age age group, but it's a similar distribution, although at different levels in young people and old people. And again, every decade, same pattern, just different numbers. And so who has a Chiari here? Well, by the current standard, if we're using the 5 millimeter rule, the people on this side of the bell curve have Chiari, at least by that MRI standard. Not necessarily symptomatic, but this is the Chiari group. This is not a completely different population of people from people without Chiari. These are an outlier, a low outlier of the population. Outliers can be symptomatic, outliers can have terrible problems. So this doesn't mean that Chiari can't be associated with lots of symptoms and problems, but it does show that it's not a completely separate population. I don't think it's a proper way of understanding this disease or illness to say we have people with normal tonsils and then we have Chiari patients, because that's not the way the human population is distributed. What we see is we have patients with high tonsils, normal tonsils, low tonsils, and so on. And a percentage of those people with low tonsils are suffering from a Chiari syndrome because their low tonsils is causing them to have symptoms. Okay? But it's not like they're a completely separate bell curve, different from the human bell curve. Does age matter? And yeah, age matters a lot. This is from an article that I wrote with Brandon Smith, one of our collaborators. And here's the bottom line with this graph. If you measure tonsils in thousands of people, and these aren't Chiari patients necessarily, these are just people getting an MRI for any reason, you can see that the tonsils, you're born with tonsils that are a little bit above the foramen magnum on average, some higher, some lower, but this is the average. Tonsils tend to go down a little bit over the first couple of decades of life. They stay down for a couple of decades and then they go up. Okay. So who has low tonsils? Well, anybody can have low tonsils at any age, but on average, you have low tonsils from about 11 to about 40 or 50. Right? That's on average, the population that has the lowest tonsils. This is purely speculation on my part, but I have always found it interesting that when are patients most likely to present with symptomatic Chiari malformation? When are patients most likely to have tussive headaches and come in suffering from symptoms of Chiari malformation? Well, on average, it's here. I don't think that's a coincidence, but of course there's no way of proving that. It's important to understand this age pattern of tonsils when we talk about how common Chiari is, back to that first question. Because now you got to ask, well, I don't know, are we talking about babies? Are we talking about 80-year-old people? Are we talking about 40-year-old people? Because it matters a lot. We looked at a pediatric group of patients that were having an MRI for any reason, and we found lots of Chiari, some symptomatic and lots of asymptomatic Chiari. Okay, much more common than the Johns Hopkins group was finding, and that bothered me for a little bit until we followed it up with this age data. But now it makes sense. The Hopkins group was mostly looking at older adults, and we were mostly looking at young kids, and we found a lot more Chiari than they did because of the different populations, in my opinion. So I think it fits, I think it makes sense. Chiari is relatively common on MRI, and it's much more common in children than in older individuals. Doesn't mean older individuals can't have it, but it's definitely more rare. Does tonsil position matter? 5 millimeter rule, maybe it's a nice starting point, doesn't matter that much. But in general, the lower your tonsils are, the more likely you are to have symptoms. That's irrefutably true. That does not mean that if you only have, in quotes, 5 millimeters, you can't be symptomatic. Absolutely not true. We see 5 millimeters symptomatic all the time. That does not mean that if you have 20 millimeters, you're definitely symptomatic. That's not true either. We've seen asymptomatic 20 millimeter patients. But in general, if all you know about somebody is their tonsil position, the lower the tonsils, the more likely they are to have symptoms. Okay, we've shown that. These are our patients here, essentially looking at the 5 to 8. Relatively small percentage were judged to be symptomatic and had surgery. 9 to 12 bigger, 13 to 16 bigger, 17 plus, vast majority even of the 13 group were judged to be symptomatic. 17 plus, vast majority were symptomatic, but not everybody. So tonsil position is not a perfect marker for symptoms, but that doesn't mean it's not relevant. It is relevant on some level. Same thing with SYRINX. Who, with a Chiari malformation, is most likely to have a SYRINX? There was an article published about 10, 15 years ago with a very small number of patients that made the claim that an intermediate amount of tonsil herniation or lower tonsils was most likely to result in a syrinx formation. I don't believe that. I just believe that was a study that had a very small number of people. When you look at actual large numbers of patients, what you find is just like the symptoms, is that anybody can have a syrinx, whether you're 5, 10, 15, 20, but the lower you go, the more likely you are to have a syrinx. So on this graph, the blue patients had a Chiari but no syrinx. The red patients had a syrinx. You can see getting lower and lower and lower and lower. You're seeing relatively more red and relatively less blue. So tonsil position does matter. It matters for symptoms and it matters for syrinx. But there's no rules. It doesn't mean somebody without a lot can't have a syrinx and symptoms. So I'll summarize this part and we'll move on to a couple other quick considerations. So I don't consider 5 millimeters a cut point. I don't think anybody really should. It doesn't have definite pathological implications, meaning not everybody more than that is sick and not everybody less than that as well. It's not a cut point. It might be a valuable starting point. 5 millimeters is the low point of a population distribution. Okay, humans are all somewhere on that curve. And if you have a Chiari malformation, you're on the low end of that curve. And a percentage of people on the low end of that curve have symptoms that we call the Chiari syndrome. And the lower you are, the more likely you are to have symptoms that we call the Chiari syndrome. Same thing with syrinx. The lower you are, more likely to have syrinx, and then age matters. So another real basic question that I think we need to to do a better job answering for patients is my Syrinx associated with my Chiari? Let's say I've got a Syrinx and I've got a Chiari. Well, that should be obvious. Chiari causes Syrinx, of course my Syrinx causes my Chiari. I think that's true in general, but there are important exceptions, which we'll talk about. This patient has a Chiari, has a Syrinx. I don't think this is controversial. This patient has a Chiari that's causing a Syrinx. Same thing here, has a Chiari, has a Syrinx, not controversial. Okay. What about this? I didn't show you the brain, but let's say this patient has a Chiari malformation. And this Syrinx is thinning out of the spinal cord here. It's a lot thinner. It's not up near the Chiari malformation. It's lower down. Is that associated with the Chiari? And what about this one? Again, lower down, not near the Chiari. This one's really skinny, real thin. Is that associated with the Chiari? And I think that would be controversial right now. We recently did an analysis where we tried to shed some light on that situation. And here's the bottom line. We looked at a very, very large number of patients with a Syrinx for any reason, whether they had a Chiari or a tethered cord or a spinal tumor or no reason that we could actually find. They didn't have any of those things. And then we said, what does the Syrinx look like? And the people with Chiari malformations, all circled in red, had great big wide Syrinxes, and the people without a Chiari malformation or a tethered cord or no reason at all had skinny Chiari malformations. This is width here, so lower means skinnier, higher means wider. Same thing with location in the spinal cord. When we look at Chiari patients, they were all, or for the most part, high up in the spinal cord. And when we looked at people who we didn't know why they had a Syrinx or they just had a tethered cord, a different cause of a Syrinx, they were lower in the spinal cord. We put that information together, we make a graph, and we say the position of the Syrinx is here, what we call the y-axis, and the width of the Syrinx is here on the x-axis. And you can see what seems to be two different populations, right? There's a group that has Chiari and a group that doesn't have Chiari, and although there's some overlap, I think this is helpful, at least it's helpful for me. Because if somebody comes in and let's say they have no symptoms, but they've got a Chiari and the Syrinx, but it's a really wide Syrinx and it's really high up, I would be more likely to attribute a cause and effect relationship to that Chiari causing that Syrinx, because we know this looks like what a Syrinx looks like typically in the Chiari malformation. If it's really low, if it's really skinny, unfortunately, that looks like what we would call an idiopathic Syrinx. That cause and effect relationship, although you never say never, the cause and effect relationship is less settled in my mind. Okay, and that becomes important when we talk about who's supposed to get surgery and who's not. So is Chiari associated with Syrinx? Yes, there's no question about that. That's not controversial at all. But there are important exceptions to understand. Not all Chiari patients have a Syrinx, although most Chiari patients that get surgery have a Syrinx. That's not true for most Chiari patients in general do not have a Syrinx. And not all Syrinx patients have a Chiari. There are several other common causes of a Syrinx, and it's important to understand when evaluating a Syrinx who has a Syrinx caused by the Chiari and who has a Syrinx that's associated with something else. Not all patients that have a Chiari and a Syrinx have a Chiari-caused Syrinx. Most do, but not all. So again, looking at these examples, I would say that these two examples are classic examples of a Chiari causing a Syrinx, and for many surgeons this would be a reason to offer surgery. Not so much this one. This one would be highly controversial, and without symptoms I personally would not operate, or I would assume that I would not help this situation. Same thing here in this skinny Syrinx. There's no current evidence to think that we as surgeons can help this Syrinx by operating on a Chiari malformation. Is Chiari associated with hydrocephalus? Kathy made remarks at the beginning that hydrocephalus is associated with Chiari, and I agree that Chiari is associated with hydrocephalus, but just like Syrinx, I think it's important to understand that there are important exceptions. So here's a person that I saw a few years ago, and again, you can see Chiari malformation, tonsils are low, Syrinx, cyst in the spine, and it might be harder to appreciate, but the fluid spaces in the head, the ventricles, are large. So that's hydrocephalus. hydrocephalus. That's what we mean when we say hydrocephalus. And again, you can see in the image on the right, the fluid spaces, the white spaces, are too large. So this patient has a Chiari, has a Syrinx, and has hydrocephalus. So what's going on? Did the hydrocephalus cause the Chiari? That happens sometimes. Did the Chiari cause the hydrocephalus? Well, that happens sometimes too. So you can understand the dilemma, which came first. It's important to try to understand which came first because that can lead you to the correct treatment. I think in general, at least for me, I try to treat the cause, not a downstream effect. I think this was a difficult decision. In this patient, I thought that the Chiari was sufficiently impressive on imaging to assume that the Chiari was the generator here, and here's some intraoperative pictures. And I think many people in this room are probably used to looking at this sort of image, but this is Chiari surgery being done, and you can see the cerebellar tonsils sitting there up top, hanging down like tonsils in the back of your throat. And what I wanted to show you here is we're working on dissecting this white tissue between the tonsils and covering up the fluid spaces in the head. And this is an arachnoid veil that was really preventing good CSF circulation in this patient. And here you can see a tiny little hole that we've opened up in it, and then a progressively bigger hole. And now we're into that normal spinal fluid space in the head. And I think this is an important step in Chiari surgery, at least in those patients for whom you've already gone to the step of opening up the dura. This group probably all knows the controversy about opening the dura or not opening the dura. I think if you've already taken that step, you've already opened the dura, then this is an important next step. And so we do this in all of our cases here. And we bring the tonsils up. We usually apply heat and bring the tonsils up. And here you can see we're looking way sideways. And I frankly usually like to see some of the nerves off to the side and some of the arteries over there to know that we've brought the tonsils up enough. So this is a typical operation that we would do when we open up the dura. And in this case, again, a little bit of guesswork went into that, but in this case that ended up working out okay. This patient was not treated for hydrocephalus, and yet just a good Chiari decompression has managed to lead to resolution not only of the spinal syrinx but also the hydrocephalus. Okay, doesn't always work out like that, but in this case it did. So that's an example of where hydrocephalus undoubtedly is related to the Chiari malformation, and in my opinion was probably even caused by the Chiari malformation. The trouble is when you hear, whether it's seeing people for a second opinion or you're on a message board, when you hear of hydrocephalus complicating Chiari, it's not typically that sort of a scenario. This is a more typical scenario. A patient who has a significant Chiari malformation does not have hydrocephalus. These ventricles are not big. So there's at least no evidence for hydrocephalus here. Had a Chiari decompression, and you can see after the Chiari decompression has all this fluid back here. This is all fluid. That should be in the head, but it's not. Now it's under the skin in the back of the head. Same thing, another patient there. All the white in the back of the head. And this is called a pseudomeningocele, and this is a complication of Chiari surgery. This is what happens when the fluid that's supposed to be inside and it's supposed to stay inside is allowed to come out into the outside. This is associated with terrible neck pain and ongoing Chiari symptoms and so on. And this is an all too common complication of Chiari surgery. And when we see this, in my opinion, all too often, what I hear next is, well, it turns out I had this because I had hydrocephalus. Hydrocephalus can cause that, that's true, but I think more often than not, it's not somebody who has hydrocephalus, it's somebody who needs to have a proper closure of the back of the head so that there's no more fluid leaking out of the back of the head, rather than putting a shunt in and leading to more and more and more downstream troubles for those individuals. So is hydrocephalus associated with Chiari? Well, absolutely it is. I showed you an example where I think there was no doubt. But I don't think it's extremely common. I don't think it should be seen in 10 or 20 or 30% of any surgeon's practice. I think it should be, for a busy Chiari surgeon, I think it's something that comes up every now and then. Pseudomeningoceles, though, are a common complication. The fluid in the back are a common complication. I personally don't believe that most of them are due to hydrocephalus. I think most of them are due to not closing the back of the head properly. So if we ever get a pseudomeningocele, which thankfully is very rare, we would recommend re-exploring. In other words, opening up the back of the head again and fixing it properly, rather than putting a shunt in. So pseudomeningoceles, again, not treated with a shunt as a first line of therapy, in my opinion. Other associations, there's lots of other associations with Chiari. Some are very important and are probably worth hours and hours and hours of discussion by themselves, and some I think are relatively coincidental and not important, not necessarily a cause and effect relationship. And there's lots of examples of this. I've put several examples here: acute porphyra, skin problems, lots of anxiety disorder, and so on. There's not a great deal of medical evidence for some of the things we see reported with Chiari. The trouble is Chiari is being diagnosed with increasing frequency. It's no longer a terribly rare diagnosis. And when something is seen that frequently, it's not an unexpected finding to see that in one Chiari person in a million, they're going to have this other thing too, or this other thing too. And that doesn't mean that the Chiari cause this other thing. It just means that sometimes rare things happen rarely. So a common finding and a common symptom, there will be a coincidental overlap sometimes. And the onus is on us, people who are researching Chiari, and you, members of organizations that are helping to support patients with Chiari, to ask us to prove these associations are real, because sometimes they are and sometimes they aren't, and we really need to do a better job of scientifically proving that these associations are real. This is a website. Any of you that like science or math, I recommend getting on this website. It's really interesting. It's called Spurious Correlations, and basically their idea is they have 10,000 values for different things, and they look at what's correlated, what is related to what else. And it's obviously completely coincidental. Here they show two lines, a yellow line and a red line, with almost perfect correlation. The yellow line is the number of people who died becoming tangled in their bed sheets, and the red line is total revenue generated by skiing facilities. Perfect correlation, because this group has looked at 10,000 factors and just seen what actually worked out. And I think we have to be careful about that when we're examining diseases scientifically, to say, okay, this happened with that. That doesn't necessarily prove cause and effect. Maybe it did, maybe it didn't, but we need to be careful. This has been somewhat relevant, I think, to the Chiari community recently. There's been some talk about obesity causing Chiari, and there have been several bases for that, but one of the bases for that was an analysis that looked at Chiari patients with SYRINX and Chiari patients without SYRINX, and they found that being overweight did not cause a SYRINX, being obese did. Being normal actually would seem to be riskier than being overweight. To me, this is a small number of patients with data that's just all sort of mixed up, but the conclusion was that obesity caused a SYRINX. I didn't think that was true. We studied it in our own population with a much larger number of patients, and looking at where somebody's tonsils were, first on what their body mass index was. It's essentially a wash. The tonsils actually seem to get a little bit higher as people gained body mass index or got heavier, and then got a little bit lower later. But again, there wasn't a significant difference. So in my opinion, the recent talk about obesity being a cause of Chiari is at the very least overstated. What about chronic fatigue syndrome? This is extremely controversial, and I think perhaps the most controversial thing I'll say today. I'm going to fall back on my national organization, the American Association of Neurosurgeons. They've actually come up with a position statement on neurosurgery for chronic fatigue syndrome, and the position statement is very simple. Our major national organization has said, don't do this. There's no evidence that it helps. Our organization doesn't take a lot of position statements. Here's every single position statement they've made between 2014 and 1998. There's a handful of them. And Chiari being a relatively niche type of surgery within neurosurgery, I think it's remarkable that our group has actually come up with a position statement. I wasn't involved in creating this, but I think it's important for Chiari groups everywhere to see this information and understand at the very least that it's extremely controversial. And I think more importantly, the vast majority of neurosurgeons right now are strongly arguing against having surgery for chronic fatigue syndrome until there's any evidence for it whatsoever. And right now there's no evidence for it. I'm going to give maybe just a couple more minutes, and then we'll wind up take some quick questions. Natural history. Natural history, that's sort of a fancy term for, well, what happens if somebody is doing real well and we make a decision to not do surgery because they're doing well? Are they going to inevitably get sick later or not? And the answer is not necessarily. Here's somebody that was involved in a research trial here at the University of Michigan. And I think he was paid $100 or $200 to sit in an MRI scanner for an hour and get a scan done. He felt great. He's just a normal, healthy young man. And here's a scan. He has a Chiari malformation and he has a substantial cervical syrinx. I'll be honest with you, I probably would have recommended surgery for that individual. I typically recommend surgery for patients with large cervical syrinxes, regardless of symptoms. Not everybody does, but a lot of people do, and I'm in that number. He saw a different surgeon, probably a good thing for him, because here he is 6 months later, the syrinx had gone away, which at the time I thought was remarkable, but we've seen more and more and more examples of that over the years. Another example, again, same patient, left and then right. Chiari got a little better over time, left and then right. Chiari got better over time. This used to be considered remarkable. There used to be individual patients like that reported in our literature saying, can you believe this happened? And now our answer would be, sure, of course it happens. It does happen to some individuals. The trouble is the reverse can happen too. You can have a scan that doesn't look too bad and no symptoms, and then we know that 10 years later you can have a scan that shows a worse Chiari or maybe a brand new syrinx or maybe new symptoms. So we know that it can go in either direction. And that's what some of these natural history studies are showing now. It's essentially 3 large natural history studies. One of them was ours, one of them was from Miami, and then the one at the top was from Rome. And they're all basically saying the same thing, which unfortunately is that if I know somebody is doing well, they have a Chiari malformation, but they have either no symptoms at all or relatively few symptoms, they choose to not have surgery. Their life is pretty good. They don't want to go through brain surgery. And I have to advise them, well, what am I going to be like in 10 years? And the truth, what all of these papers are showing, is that probably things are going to be about the same in 10 years. If you're doing great now, you're probably going to be doing great in 10 years, but a small percentage are going to get worse and are going to get new symptoms and are going to come to surgery. And actually a small percentage are going to get better too. And they tend to balance out. Here's another one of these bell curves. And here's what happens to our patients that are doing well, that choose to not have surgery over time. The big line in the middle is everything looks exactly the same 10 years later. And here's people who are actually getting better, in some cases dramatically better. And here's people who are getting worse, okay, over a decade. So when I advise patients who want to know how am I going to do in 10 years, well, in any individual case, I don't know where you're going to be on that bell curve. Maybe you're going to be an outlier on the left or the right. More than likely, you're going to be in the middle. You're going to be about the same. So that seems to be the emerging consensus on natural history of Chiari. And then finally, what are we going to do? What are we going to say for people that want to participate in an active lifestyle, for kids that want to play sports or adults that want to play sports or be active if they have a Chiari malformation? This has been controversial over the years. In the past, some real national leaders in traumatic injury have advised against patients with Chiari participating in sports. There has been no strong evidence to support that, except to say, I suppose, probably it's a safe position. You're never going to be sued if you say don't do anything. You're never going to be responsible for a sports injury. So it's a safe thing to say, but is it really evidence-based? I don't think so. There are 17 cases in the world literature of trauma resulting in a serious injury to somebody who has a Chiari malformation. 17 patients is a lot, and I'm not minimizing the meaning of that for those 17 individuals. But when you put that in the proper context of how many times Chiari is being diagnosed in the United States these days, it's a tiny, tiny, tiny percentage. And then you factor in the cost to individuals to say, a happy 10-year-old with this diagnosis, we're going to tell him he can never play sports. That's a big deal. So we've always been permissive in our practice on this basis. We've always allowed people to participate in sports with Chiari malformation. And we finally have some data based on that. Again, busy slide. The bottom line is we had a lot of patients. We had 4,600 sports seasons. We let people participate in sports, and we followed them very carefully, and we said who's been in trouble, who hasn't been in trouble. Bottom line is, after 4,500 seasons of sports in our patients, we have not seen any serious permanent injuries in the Chiari population, not one. That doesn't mean it can't happen, because people, even without Chiari, will have a serious permanent injury every now and then. But what it does tell us is that the rate seems to be very, very low. So we're going to continue with our permissive practice. We're going to continue to allow patients with Chiari to participate in sports. So this is, I think, my last slide. What we might know about Chiari. Number one, there's no consensus about how to define Chiari, and that's a really big problem, because we all want to talk about Chiari, and sometimes we're not even talking about the same thing. Symptomatic Chiari is, I should say, relatively rare, but being diagnosed more commonly. Asymptomatic Chiari on imaging is extremely common. Both symptomatic and asymptomatic Chiari prevalence is affected by age and gender. Okay, so teenagers, young adults, most likely to have Chiari. Girls and women, much more likely to have Chiari, starting in the teen years and going on through adulthood. But boys, as young children. SYRINX is common. The Hydrocephalus Association, in my opinion, is real, but is sometimes overstated because of that surgical complication phenomenon of the pseudomeningocele. I don't believe that Chiari is associated with obesity, at least not strongly so. I believe that tonsil position is not the be-all and end-all of discussing a Chiari or deciding when to operate on a Chiari, but it's not irrelevant. The lower the tonsil position, the more likely you are to be suffering from symptoms, and the more likely you are to have a syrinx. The 5 millimeter rule is seriously flawed. Nobody's come up with a better starting point, though, yet. Everybody's trying. We're trying. Actually, we have an ongoing study right now, but it's not completed yet. Natural history is usually good in most cases. If you're doing well now, if you don't have any symptoms now, or you have minimal symptoms now, that'll probably be true in 10 years. No guarantee, but it'll probably be true. And again, we don't restrict the activity of Chiari patients that are currently asymptomatic or not having surgery. So that's what we might know about Chiari. I think we still know a lot more about the cat's eye nebula, but hopefully we know a little bit more about Chiari these days than at least we used to. So again, thanks to all of my collaborators at U of M. As I said, it certainly does take a village, and my partners who see and operate on Chiari malformation patients are certainly very valued. Dr. Sager, Dr. Marasco, and Dr. Garten. And then all the other collaborators you see are people who we've done research with on Chiari malformation, and we honestly could not have done any of that without them. So thank you to them, and also thank you to the Chiari and Syringomyelia Foundation. It, I think, is critically important that patient advocacy groups like the CSF for Chiari exist and continue to drive the Chiari agenda forward in a positive direction. It's important for researchers. Sometimes we need to be brought back on track a little bit, and we hear patient stories, and that's very helpful for us. And I think it's critically important for patients too. I think one of the most important functions is to bring everybody together in one room, people who care deeply about Chiari and trying to improve the future for patients with Chiari now and people who are going to be diagnosed with Chiari down the road. So CSF is a wonderful organization, so thank you to all of you for supporting it and the work that it's doing. And that's it. I'll take questions from the audience if anyone has any. I should say also Dr. Marasco and Dr. Sager in the back can take questions also.
Do you have questions for them?
Yeah. Mm-hmm. Yes.
You said that in one of your slides that it was more likely for surgery to take place for a child for an adult versus an adult.
Yeah.
Do you believe that that's an overuse, or is it more pressing for a child to have surgery? What are some of the factors that go into making a decision for surgery for a child versus an adult?
Well, I think the data that I showed you, we can say is a true thing. This is what's happening. We can't say why it's happening. The data doesn't really tell us why it's happening. I think I can tell you in my own practice, I am probably a little bit more likely to operate on a child than an adult under some circumstances. It's probably not an extremely major factor, but a child, let's make up a scenario, a 5-year-old with a big spinal cyst, SYRINX, in the cervical spine, I would worry a great deal about how that person is going to grow up and if they're going to develop symptoms and trouble later. If somebody is 50, which is certainly not old, but at some level, I would factor in, well, they made it this far and they're asymptomatic, they feel great. So maybe you'd be a little bit more reluctant to offer surgery just on the basis of the spine cyst. So that's just one example. But a symptomatic older person is certainly a good candidate for surgery. There's nothing about age that says you can't have surgery. But yes, I think it's easy to imagine a scenario where if everything else is equal, it maybe is one factor that suggests being a little bit more conservative in an older person, if that makes sense. I don't know if Dr. Marasco or Sager want to weigh in.
Kids also commonly present with scoliosis when they have a SYRINX.
Can you turn the microphone?
And I think that the SYRINX is certainly something that when they have the scoliosis and the SYRINX, they often come from the orthopedic surgeon who is asking, what are we going to do before we do the fusion? And we know, for example, that if we do a decompressive craniectomy and the SYRINX gets better, if the scoliosis is not greater than 20 degrees, the chances of it correcting or becoming stable go up tremendously. Once you start getting above 40, 50 degrees, we know that the child is going to require a fusion, and at the time of the fusion, there's going to be a lot of hardware that's put in place. So you're not going to be able to follow the SYRINX. So there's lots of confounding factors, I think, in kids that make you push it. And the other thing is, in the adult population, often the spinal cord will work just fine, even with the SYRINX in place. You may not need to know about it. But in kids, for some reason, that association of Chiari, SYRINX, and scoliosis is often seen.
Other questions? Yes.
You made mention to an open dura versus a non-open dura controversy. Can you elaborate just a little bit what that is?
Sure. So there are lots. The question was if I could elaborate on opening the dura during surgery versus not opening the dura during surgery and what the controversy was regarding those two practices. And I think as a starting point, it's important to understand there are lots of different ways of doing a Chiari decompression. The general similarity is you're trying to make the space in the back bigger, but lots of different ways of accomplishing that. Boiled down to their essentials right now, we can say whether everybody tends to remove the bone in the skull. Not everybody, but it's a very, very common practice. Most people, but not everybody, removes the back of the C1 ring or the top part of the spine. And then some people open the dura and some people don't. The dura is the brain covering. Of those people who open up the dura, some people will apply heat to the cerebellar tonsils to try to so-called shrink them up into the head again, and some people don't do that. Some people go to the additional step of opening up into the fourth ventricle or the fluid space, the way we showed in some of the slides here, and some people don't do that. By typical scientific standards, there is no reason right now for anybody to say this operation is better than that operation and I can prove it. There's nothing out there in the literature right now, in the whole world medical literature, that says this is better than that and it's proven. There are some general trends that are starting to emerge. In general, I think a lot of people that are opening the dura and coagulating or lifting the tonsils up will claim that the efficacy or the chances of the operation working are higher with that operation than not doing that part of the operation. But in general, most people will acknowledge that the side effects of that operation, the chances of something going wrong and having a complication, is also higher with opening the dura and lifting the tonsils up. So the question is, can we generate enough of a benefit from those additional steps to justify the additional complication rate? And I think that really comes down, in my personal opinion now, I think that comes down to what your complication rate is as a surgeon. If you have a low complication rate from opening the dura and doing the additional steps, if it's very unusual to have spinal fluid leak problems or pseudomeningocele problems, then I think that surgeon can justify opening the dura. If you're seeing complications in a high percentage of the people that you're taking care of, getting leaking from opening the dura, pseudomeningoceles and so on, then that surgeon might consider a less aggressive operation, not opening the dura, doing the bone-only decompression. As Kathy mentioned, there is a trial that's just starting now. I don't think a single patient has been enrolled in it yet, but hopefully everybody will be starting soon, where surgeons and patients will agree to essentially be randomized. So somebody who everybody agrees needs surgery is either going to have one operation or the other by the same surgeon. And we will find out over the course of the years to come if one is actually demonstrably better than the other. We don't know the answer to that right now. We all have opinions. My personal opinion is that I like to open the dura, especially when there's a spinal cord syrinx, because I think it's more effective and I think our complication rate is low enough to where we can justify that practice. Other good surgeons will have different opinions though right now. Dr. Sager, Dr. Marasco, do you want to comment?
I think it does depend on the complication rate. And I think if the complication rate is low, opening the dura, particularly in the face of syrinx. I'm one of the people that try very hard to try to use ultrasound and not intraoperative MRI, a variety of other techniques. And about 20% of patients, even up as high as 30%, that I operated on where I didn't open the dura went on to require another operation. That was and that complication rate was not in my mind acceptable. Having said that, the literature reports a 20 to 30 to 40% complication rate opening dura. Maybe we're just blind to the, at least in our hands here, the surgeons that operate on here at UM have not seen that level of complication rate. It's actually fairly low.
So the risks are clearly higher when you open it. It's not necessarily reflecting a higher complication rate, but you're always taking more of a risk. Pseudomeningocele, CSF collection, as well as other things can happen when you open the dura. So you always open up that possibility, and that's why people have tried to do it selectively. The problem is, using ultrasound and intraoperative MRI, it seemed like a very good idea. But there's some very nice data to show that when you put somebody in the operative position, merely putting them in that position to the operating room, a fair number of them will appear to have good flow there, where they normally, sitting up and looking straight like we all do now, the flow is restricted. So just by virtue of flexing your neck in an operative position, you can create a flow there where there normally isn't, and fool yourself. I wish there were a better way to discern who may need it, who may not need it selectively. But as of now, I'm one of the people who open it because I don't feel that there's something that can prove it to us at the time of surgery where we need to as well. And like Dr. Marasco was saying, I don't like to take a chance of having to take the patient back to the operating room. It's not even the less invasive, I guess, the less risky operation, is still a big operation, and doing it twice is something that I don't relish and the patients don't either.
Other questions? Yes.
It's controversial, I understand, but I have a question on further testing. You have a patient, do you send them to a geneticist for ultrasound? Do you worry about these other conditions?
Well, I think that depends on the patient. I do not send everybody for a workup for a genetic condition or to a rheumatologist for Ehlers-Danlos. If I hear anything in their description of what they're going through, or I see anything on physical examination to make me think that that's very likely or possible, then I think those referrals are appropriate. But I don't send everybody. Unfortunately, there are some areas of what I would call subjectivity with respect to certain of these diagnoses, meaning it kind of depends who you see, and you're going to hear different things. And so for me personally, I think the way, at least in my personal practice, I can come to the best decisions is to have some control over that and to make referrals when I think that it's appropriate, but not every time. But I think other surgeons have different policies about that. I think, frankly, what I just described to you is a majority opinion, but there are certainly other practices that are more aggressive about looking for it. Yes?
Is there any research numbers on the hereditary values of people that have been diagnosed with this? Has there been tests on other family members throughout the research?
Yeah.
And what is that percent of other family members that come down with this?
So the question is about the genetics of Chiari malformation and what percentage of family members have it, and I think getting to screening questions and so on. First of all, there is a ongoing effort to identify a specific genetic locus for Chiari malformation, because Chiari malformation undoubtedly has a genetic component. We know that there are families where there's a whole bunch of Chiari malformation and other families where nobody has a Chiari malformation. So there's a clustering in families, therefore on some level it's genetic. But does that mean there's going to be a Chiari gene? And that depends who you ask, because that answer is not known yet. There are groups, one group in particular, that's looking really hard to try to find a Chiari gene and have come up with candidates. My personal opinion is that they're not likely to find one specific Chiari gene, and the reason for that is essentially because of this, the population distribution. These are not Chiari patients, these are just everybody that we can study with an MRI. And as I was describing to you, the Chiari group is not this completely discrete, separate group over on the left side of the screen. People who are suffering from symptoms of Chiari syndrome are outliers on the left side of this normal curve, or this bell-shaped curve. When you study genetics, when you're looking for a gene, if you saw two bell curves, a bell curve here and a bell curve here, you'd say, that's all. You either got it or you don't. There's a gene. And if the two curves are kind of separate but kind of coming together, then you say, well, okay, if it's genetic, there might be a few genes. When there's a one bell curve and you're looking at outliers in that, maybe it's genetic. And I've told you that I think on some level it probably is genetic, but just my personal opinion, I don't think we're ever going to find a one gene that's responsible for Chiari malformation. That's just my opinion. That's controversial. There are other people who disagree. But that's why I think what I think, because on a population basis, the one gene theory doesn't seem to hold water. What I do think, though, is that there's a genetic type inheritance. Personal opinion is that when we look at our families, we have some people with very distinctive facial features, and we look at them from across the room and you say, you must be Joe's brother. You look exactly like Joe. That's facial features, right? That's not a gene either, but it runs in families. And we're not talking about the face, we're talking about the back of the head, but we are talking about the shape of the back of the head, and we know that the shape of the back of the head is on some level related to the pathogenesis or the creation of a Chiari with the low tonsils, right? So I think that can run in families. It doesn't surprise anyone to know that small noses or big noses or high arches or whatever runs in families. And I think Chiari runs in families in the same way. I don't think you're going to find a gene, but I think you're going to find definite clustering within families. And either that's because of 10 genes or 100 genes, or maybe we never even discover it in our lifetimes, but there is some clustering phenomenon. In terms of whether to screen or not, my advice is if people are exhibiting symptoms of Chiari syndrome, if they're suffering, then of course you screen them, just like you would recommend for anybody. And maybe if it runs in the family, there's more awareness of Chiari, so they're more likely to get diagnosed. I think if somebody is completely asymptomatic, they have a great life, they're happy, they're healthy, they're not suffering from any symptoms whatsoever. I personally wouldn't recommend screening that person because I don't see what good we can do. We can't, if they're perfect, we can't make them better. So that's my own personal opinion. Yes.
The surgery itself, once you start it, how typically long does it take?
That depends on a lot of things. It depends if we're doing the so-called bone-only decompression or if we're opening the dura, opening up the fourth ventricle, the way I described in the slides. Depends what sort of tools and techniques we're using in the operating room. We've gone to using the intraoperative MRI scanner in many of our Chiari patients. As Dr. Sager was describing, one of the problems with the intraoperative MRI is if I put your head position like this, which is the way we do our surgery, on the MRI, all of a sudden it doesn't look so bad. If I could make your head position like this for the rest of your life, I wouldn't have to do a surgery, but nobody can go through life with their head position like that. Nevertheless, that's what we're facing. So we have to do an MRI scan after I put your head position like that so I understand what you look like in that position, which is different than when you had your pre-op MRI. And then I have to do another MRI scan after I've done what I judge to be a decent decompression to see if I've done enough. Okay, so that means 2 scans, doing at least the bone only, maybe opening up the dura as well. Bottom line is there's a lot of variation and variability depending on what path you choose to go down with that Chiari surgery, and all are reasonable. The typical operation for us right now, with an MRI scan, with opening the dura, takes several hours, 4 or 5 hours. If I wanted to do it just as fast as I could, without any of those bells and whistles, no MRI scan, no opening the dura, just the quickest operation I can think of doing, then it's a very fast operation. I'm sure if I was racing, it would be an hour or something, but we're never in a race. And I've never done anything like that fast. But so it kind of depends. It depends.
Another question for you, if I may. After surgery, for infections or anything coming up, is there some kind of time frame to where you're pretty much in the clear, or you still should be looking for things?
So, not exactly. The question is there a time frame after surgery to when you're in the clear, when you can relax that you're not going to have a surgical complication? The answer is not exactly. There's not one specific point in time. I tend to relax a little bit more every day. The greatest risk of having a spinal fluid leak, which I think is one of the worst things that can happen after Chiari surgery, is in the few days after surgery when it's recognized. Sometimes not. Sometimes you hear about people that are doing okay for a week or two and then they get it, or a month or two and then they get it. But in general, when you hear about these sorts of complications, you hear about it happening a day or 2 or 3 after surgery. In terms of infection, that also can be relatively soon after surgery, but it's usually not the first, second, or third day when it's recognized. Usually it's a week or 2 or 3 after surgery when it's recognized. If you want to know when you're really in the clear, I guess I'd be pretty relaxed 3 months after surgery. It's not going to happen. But there's not a one specific point in time when everything changes. It's a process. Yes, ma'am.
Is there research going on for pain management of symptoms post-surgery, or trying to manage the symptoms and not have the surgery? What's effective for a Chiari patient to control pain? And is there a development of substance abuse?
There is, yeah. So the question is about pain management, either for somebody who is not a candidate for surgery or somebody who had surgery that was unsuccessful. And what's effective, what's not effective, and is there the potential for abuse? The last question is the easiest, and that's true for anybody who's suffering from pain and is on especially narcotic pain relievers, is that there very much so is a potential for abuse, and it's something to be wary of. And the other thing to be wary of with long-term narcotic use is the so-called rebound effect, where it works great when you're on it and it makes you feel worse than ever when you're not on it. And that happens for people that are going through chronic pain and treating it primarily with narcotics. Now, I personally, I'm the surgeon. I'm not the person at this institution who's responsible for treating patients with chronic pain with medicines. We have people at this institution that are experts in that. One of the gentlemen on my last slide, Wade Cooper, is a real resource for a lot of my patients when they're going through chronic pain, because that's really his area of expertise. And there's a lot of things to try. I think the simplest answer is if there was one thing that worked great for everybody, then there would be nothing to talk about. We just say, everybody try this medicine and now we fixed the problem. And it's just not that simple, obviously. Nobody has found that medicine that works great for everybody. So it's a trial and error process. Dr. Cooper or one of his colleagues will say, this works well for 2 out of 3 people, so let's give it a try. And maybe you're in that lucky 2 out of 3, maybe you're not, and then you try the next thing and then the next thing. The good news is most people, although the path can be short or the path can be long, most people will go down the path ultimately to a point where they can get some satisfaction. It's not everybody, unfortunately, but most people can. And again, it's not as simple as saying this always works. This is the miracle drug for pain after Chiari decompression. I wish it was that simple. Other questions? Yes, ma'am.
I'm a research and numbers nerd. I love that stuff too. You said when you looked at everyone that you looked at and that John Hopkins looked at, and you found it more in children and they found it more in adults because that's what you were looking at.
Yeah. Well, can I interrupt for just a second? So the question is, going back to the slide I showed about the Johns Hopkins study, and you had suggested that we found it more in kids and they found it more in adults. They looked more in adults, but they found in general lower prevalence of Chiari. We found a higher prevalence of Chiari because we looked in kids. We only looked in kids. They mostly looked in adults. And that explains, in my opinion, that explains the different prevalence rates, just to clarify.
My question is kind of, did anyone look at the symptom that caused the MRI? What was what was it they don't just do, there's got to be
I understand
serious neuro symptoms before an MRI of a brain is performed, especially on little kids. Did anybody look
sometimes,
at that?
yes, sometimes.
Did anybody look at those?
Yeah, we did, and that was in our manuscript. And it's all over the map in terms of why people are getting scanned. Sometimes it's a seizure disorder. In fact, that's a relatively common reason to get an MRI in children. Having a single seizure is a pretty commonplace event in children, and so that's one reason. Falling in the playground, spells, ADHD, there's lots of reasons that kids...
Things related. I mean, falls and dizzy spells and clumsiness is a big Chiari. That's with a lot of Chiari children. I mean, some of these symptoms, because there is, yes, a lot of people have these ones, but then the circle gets bigger. The symptoms, there's so many, or maybe some of those symptoms are more common than...
I think that's plausible, and I think it's certainly possible, but if you look at the reasons why most of the scans were done, I think it's pretty easy to exclude a lot of people. And you might say falls, clumsiness, well, sure, if you're talking about a 5-year-old that's super clumsy and has a super bad Chiari. On the other hand, if you're talking about somebody who is extremely coordinated and great and healthy and happy and fell in the playground because someone pushed him, well, that's not Chiari.
Right.
So I think your question is a good one, and I think in certain circumstances that's true, and that's something to be very careful with. But I think in most cases that didn't apply to this group. Yes, ma'am.
In one of your slides, you made mention about chronic fatigue syndrome, that there was a position being made.
Right.
Is that something that you see overlapping chronic fatigue syndrome and Chiari malformation? Or are those two related at all?
No. Well, it depends who you ask. There are people who think it's related. If I can claim to represent mainstream opinion, mainstream neurosurgery right now, and that's what our national organization purports to broadcast the opinions of, has taken a very strong position statement about this. Again, we don't, as a national organization of all neurosurgeons in America, we don't take many position statements. And if you think about all the things that the specialty takes care of, Chiari is an important piece of the puzzle, but it's one piece of the puzzle. And yet this was something that the national group, all neurosurgeons take care of every problem everywhere. It was on their radar screen, and they actually made a position statement saying, as of right now, we don't think there's any evidence to support this practice. And I personally, in my opinion, I agree with that. I don't think there's any evidence to support the practice. There was a nice analysis out of Seattle a few years ago where they looked at everybody with chronic fatigue, everybody without, and they tried to see was there an overlap, as you suggested, and they didn't find an overlap, which again supports the position statement. There are certain people that you could ask or talk to that would disagree with that, and I'll acknowledge that. And we're all trying to sort through the available information as best we can and arrive at the truth. And sometimes as that process is working itself out, people arrive at different answers. And that's okay. But that's my answer. And my answer happens to talk about overlap. My answer happens to overlap with the official statement made by our parent organization.
But your organization isn't making statements that Chiari doesn't have anything to do with lots and lots of things.
Nope, the only thing they've ever made a statement about is chronic
What was
fatigue.
it that caused them to?
Because there were individuals that were doing a lot of Chiari surgery for chronic fatigue. And that made it onto the national radar screen to the point where the group thought they had to make a statement.
One other question. You said that your facility here had a low percentage complications with leakage after opening the dura. What exactly is that percentage?
It's evolving because I guess we operate on people all the time, but it's very, very low. I've seen one leak in the last 5 or 6 years. And we do lots of Chiari surgery, so I don't know. It's less than 1%. But not zero. I'd love to say it's zero. Yes, ma'am.
I have a quick, in relative to a child having a mother and grandmother with Chiari and a fussy baby, that there's nothing we can do to console them, would that be something you
Susan,
want to
I'm sorry, can you repeat that question? I didn't hear the first part.
In relative to a mother that has a baby, that has Chiari in their family, and you've got a cranky baby, you can't figure out what's wrong, is that something you want to get checked out?
Well, yeah, I think you get it checked out by the pediatrician to start with. The question was, in a family, there's Chiari in the family, brand new baby that's cranky, should we get it checked out? And I think on some level you absolutely get it checked out, but I think like any other cranky baby, you start with the pediatrician, you start with a well-child check, and you see if you can work through the common things, the real common things, the run-of-the-mill pediatric type problems. And I think if the pediatrician is recognizing warning signs of something potentially more serious than what they've seen in their practice, then I think you do refer. But I don't think I would start with the neurosurgeon or with a brain scan, not for crankiness. In a brand new baby, I think you have to work through some other things first. Maybe you go down that road and you end up with the neurosurgeon, but I don't think that's the starting point. Other questions? Ma'am?
The boy thing, the boys versus men and the ladies.
Yes.
Do you think that has anything to do with men don't go to the doctor unless they're damn near dead? Little boys, because there was that age, and it's about times that, you know, they get tough and they get hair in their armpits, and they're tough now, they're men, and they don't go to the doctor. They've got to be nearly dead before they go to the doctor. We go to the doctor, something is wrong, I don't know what it is, but something is wrong, and I'm going to go find out about it. Until I don't like doctors anymore after 10 years, and then I don't go for 5 years, but men don't go.
Yeah.
I mean, getting them to get their physical is like, you got to grab them by the short hairs and drag them in. So do you think that has anything to do with that number?
Yes.
Because they don't complain, they just go about their day. And
So that's a good question. The question was, what is responsible for the difference between young boys who are more common, or at least more commonly getting operated on than young girls, and then after that, starting with teenage girls more likely to get operated than teenage boys, and women more likely to get operated than men. What is responsible for that difference? And it had been suggested that perhaps some of this is the reluctance of adolescent boys or adult men to go to the doctor until their symptoms are much more severe. And the answer is, well, this is what's happening. We know that young boys and adolescent girls and adult women are more likely to go in than their counterparts of the other gender. we know this is happening in America. We can't explain why it's happening. I think on some level, perhaps you're correct. Perhaps it's a gender behavioral difference. There also, though, is at least some responsibility for tonsil position, pure and simple. I showed you a graph. You said you liked graphs. One of my graphs, if I can find it, showed that tonsil position was its lowest. I think we're coming up on it. Yeah, so tonsil position is the lowest right at the symptomatic age range, which I don't think is a coincidence. Just my opinion. I think that this probably is responsible for, well, how come people have symptoms now? Why not?
What age does the skull harden all the way? Completely, you're done growing, your skull is not moving anymore.
Well, it's a process. You've done a lot of your skull growth by 2 or 3 years of age. Okay, so it's not only that, although it's true that we see, not just with Chiari, with a lot of other congenital and developmental problems, we see a lot of changes up to about 4 years of age, and then less change. But I don't think it's only due to that, because the process is ongoing throughout life. So I've showed you here that I think symptoms might be related to tonsil position, and well, that's where the lowest tonsil position is when people are symptomatic. If I break it down by gender, in the symptomatic age ranges, in adolescents and young adults, girls and women have lower tonsils than boys and men. I didn't show you those data. I couldn't show you everything, but that's a fact too. So maybe, sure, you've speculated that maybe it's behavioral, gender differences in behavior, and I can't say that it's not, but I think maybe, but also maybe on some level it's just simply because girls and women have lower tonsils. And I think tonsil position matters, at least on average it matters. And so that's probably driving some of the difference too. Yes, ma'am.
Coming from a mom that has a 9-year-old that had 2 decompression surgeries and looking at his third, how common is it to repeat the surgery?
The question is, how common is it to repeat the Chiari surgery? I think it's very rare, at least it should be. It sort of depends what the first operation was. We got into the debate earlier about, do you open up the dura, do you not open up the dura? If you don't open up the dura, if you do the relatively minimal operation, especially in a very young child, it's not unheard of to repeat it later. It shouldn't be a common practice. It shouldn't be done frequently, but it comes up from time to time. If you do any operation on an extremely young child, babies are great at healing, so they heal up your surgery, and it's like you didn't do anything 5 years later. And so it's not all that unusual to repeat a surgery that was done on an extremely young child. The Boston group showed that probably 2 decades ago, and I believe that that's true. But those are exceptions, and that should be a very rare instance where Chiari surgery has to be repeated. And those are the 2 usual reasons for why that would be the case. If Chiari surgery was done, especially with a dural opening and everything was done properly, I think it should be very unusual that another decompression is required. In some instances, if somebody failed to get better with a really good Chiari decompression, maybe the first operation was done improperly. Maybe, I can't say. We got a hypothetical situation here. But maybe everything was done great, and maybe these symptoms aren't going to get better with Chiari surgery. One of the pieces of advice that I try to remember sometimes when confronted with a situation like this, I've heard it's attributed to Napoleon Bonaparte, but I'm not sure. But supposedly at the Battle of Waterloo, he was losing, and somebody said, you know, throw in your reinforcements now. And supposedly he said never reinforce failure, like he was losing, so why does he have to lose big? You know? And I have to think about that sometimes when somebody has failed Chiari surgery, when they're still experiencing terrible symptoms after a Chiari surgery. The decision is, did they have a good operation in the first place or not? Because if not, maybe we can improve on that. Maybe we can offer them some symptom relief. Is there something else we're missing? Do they have another diagnosis going on that we can offer them some symptom relief? Or did they have a really good operation the first time, and another surgeon or a different operation is not necessarily going to lead to a better result? So that's sort of the general approach I would take to that, is I never say never. Sometimes you can help somebody with a second operation. I try to be extremely cautious about that, though, because simply if you look at a national level and you look at who is helped by Chiari surgery, most people are helped by Chiari surgery if they need Chiari surgery. The people who are helped by a second Chiari operation, if the first one was performed properly though, is much lower. Third is much lower again. So as a surgeon who's trying to operate on people to help people, but not necessarily to put people through a surgical experience that's not going to help them, I think it's proper to become more and more cautious about recommending surgery the more people have already been through. So that doesn't answer any specific question, and I know you kind of have a specific question, but that's just a general way of approaching that problem that I hope is helpful. Yes, ma'am.
So with following similar vein with that question, if you have had the surgery and the dura was open and the fourth ventral was opened and surgery was a failure, what point do you say surgery was a failure? Do you have a 1 year, 2 year rehabilitation? How long, and I know it's case specific, but how long would you expect to?
It is.
How long would it take to reach your optimal healing?
Yeah, so the question is, how long does it take to heal from Chiari surgery? When do we define failure? At what point after surgery? As you yourself acknowledge, I do think it's case specific. I frankly don't have any kind of idea fixed in my mind that says this person has to be better by 2 weeks or 2 months or 2 years after surgery. I'm going to call it a failure. Certainly by the last situation, by 2 years after surgery, if somebody is still experiencing just as many symptoms as before surgery, I would personally call that a failure of mine. 2 months is too soon to give up on it, I think. I would still be very hopeful that things are going to improve over the course of the several months after that. But there's a gray area in there. I don't think anybody has a real strict definition for that. I certainly don't. I am very hopeful that symptoms improve relatively quickly after surgery, like within a month or 2 or 3, and I'm frankly relatively disappointed when I don't hear that from patients that I've taken care of. But not everybody improves that quickly, and there are exceptions, and there are people who feel great at a year that felt lousy at a month. Other questions? Yes, ma'am.
Now, is Chiari getting more well-known in all the hospitals throughout Michigan? Because I can remember even with my daughter, nobody ever in the past 10 whatever years, nobody is even familiar with Chiari, and a little bit more you start hearing about it, a little bit more. It was even on Chicago MD like a month ago. What's Chiari? But most people look at you like you're crazy, and even in other hospitals, I often wonder, like if you have complications and you need to go to like another hospital quickly, are they going to look at you, or is somebody actually going to know what the heck you're talking about?
I have nurses and doctors actually Google it while in the room with me. I get up and leave. I'm like, never mind, I already know more than you. Forget it. I'll start over. It's that bad.
Oh, that's rare. I think I've heard of it.
Right. Sorry, I'm out.
So the question was, is Chiari becoming more widely known in the medical community, in community hospitals around the country? And I think the short answer is yes, it is becoming more widely known. That doesn't mean that everybody knows what it is, and it doesn't mean that everybody in every hospital knows what it is. Certainly not. You've all shared your personal experiences of being in a healthcare setting where people didn't know what it was, and that's been frustrating. And I think that situation is improving. I really do. I think that these days, more and more textbooks are including mention of Chiari. I think more and more primary care physicians and nurses are becoming more and more familiar with it, but that doesn't mean that they know a lot about it or as much as maybe they should know. So it's an ongoing process. Personally, I'm optimistic that I think it's better now than it was 10 years ago, and I think that will continue to be true. I think 10 years from now, it'll be better again.
And this is kind of relative to what she was saying and about a failed decompression, because my second surgery was not a failed decompression, but the tethering that happened from the first surgery.
Yeah.
That's an issue.
Yeah, that's right. So this question addresses reasons for a failed decompression, and it sort of gets back to what your question was earlier too about what is the likelihood that a second decompression is going to help or a third decompression is going to help, and it depends on a lot of things. And one of the main factors, which we brought up earlier, is, well, why did the first one fail? Was it a great operation? Does everything look great on the post-op MRI? Just can't see a single thing wrong with it? Or is there a problem on the MRI? Is the brain tethered to the dura? Is it stuck down? Does it look like the Chiari wasn't fixed adequately? You don't like to hear those bad things about your MRI, but frankly, as a surgeon who's evaluating somebody for maybe a second operation, if I see a problem on the MRI, it makes me feel like there's a better chance of fixing it than if I don't see a problem on the MRI. So I'm much less likely to offer a second decompression to somebody who comes in with an MRI scan that looks brilliant, looks like they had a good decompression the first time. Then if somebody comes in with an MRI scan and I say, this is not the way I would really want it to look. It looks like the brain is stuck to the dura, or it looks like there hasn't been an adequate decompression. So that's right, if that answers your question. Okay, sorry. Statement, not a question.
So kind of, maybe just for me to clarify her question, is the tethering that's caused from a decompression, is that scarring tissue that's, so, okay, then if you have a patient who has had previous surgeries and other issues that maybe shows that they're more susceptible to a large amount of scar tissue, would you handle a surgery differently then?
Yeah, I think that depends. So the question was about scarring, and if I had a patient that I knew was very susceptible to scarring from other surgeries, would I handle that person differently? And I think, yeah, I might, depending on the exact situation. First, I should say that I think scarring is a relatively unusual complication of Chiari surgery. You don't see it a lot. I have seen it, but I don't see it a lot. And for me to make that diagnosis, I like to see that the brain is actually stuck on the dura. And it's usually fairly obvious on the MRI if that's the case or not. In terms of preventing it, the number one way of preventing it is not opening up the dura in the first place. You're not going to create scarring unless you open up the dura. I usually do open up the dura. I usually don't get scarring. So scarring, again, is unusual. I think in a normal practice, it's not worth, because the rate of scarring is so low, it's not worth doing something differently just to prevent scarring. In your hypothetical situation, if somebody was known to cause or to be a scar former, if you can put it that way, would I do something differently? Yeah, if I knew ahead of time that this person was likely to form scars because if they had, let's say, a spine operation and had a great big scar and their spinal cord stuck to the dura or something, I would be less likely to open the dura in the brain in that person because I wouldn't want to create a scar. And it's very hard to not create a scar other than just don't go in there in the first place if somebody is going to form a scar, if they're a so-called scar former, if that answers your question.
How common is it to remove the tonsils?
So the question is, how common is it to remove the tonsils? I think it's a very reasonable practice. I know very reasonable practitioners that do that. I personally don't do it. I've never found it to be necessary. I do other things instead. But there are surgeons out there who I think are very good surgeons that have chosen to do it that way instead of the way I do it. So I think it's a reasonable practice. Your question was, how common is it? In my opinion, it's unusual. If you look at, you get a hypothetical group of Chiari surgeons in this room, and you ask for a show of hands, who's doing this, who's doing that, who's doing the other thing. The smallest group in the room would be the ones that remove the tonsils. Doesn't mean they're wrong. I think, as I said, it's reasonable. It's not what I do. It's not what most people do. It's a minority practice. But not making a judgment about that. I think it's reasonable. Okay. Well, I think that's it for questions. Again, thank you so much, everybody, for all of your great questions. Thank you for coming tonight, and thanks to Kathy for organizing the meeting, Susan for organizing the meeting as well, and to everybody at the CSF for bringing us together. Thank you.
Thank you, Dr. Maher, Dr. Sager, and Dr. Marasco. We really appreciate what a great informative lecture. Can't wait to get it up on the website. Thank you all for coming out tonight, and remember to see Amy about the walk. We hope that you can be part of Be the Hope this year. Okay, thanks. Be safe, travel safe.